Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology, sponsored by EUROTIMES. I'm Harminder Dua. We're here at the 6th EuCornea Congress in Barcelona. Today we will be talking to Professor John Dart, who's Professor of Ophthalmology at the UCL in London and also a consultant ophthalmologist at the Moorfields Eye Hospital in London. Dr. Dart is delivering the EuCornea Medal lecture on his latest research in the area of cicatrizing conjunctivitis. Welcome, John, and congratulations on the EuCornea Medal lecture.
No, I'm delighted to have been asked. Thank
Great.
you.
Well, richly deserved. Let's talk about cicatrizing conjunctivitis. How common is it, and what tips would you give to the cornea specialist and the general ophthalmologist in clinical diagnosis of early cases?
Well, it is a rare disease, and we did an incidence study in the UK, and it's about 1 new case per million, but these patients live a long time, and we think the prevalence is more likely to be about 1 in 30,000, and it's something that turns up in corneal and external disease clinics fairly regularly, in big centres quite regularly. And it creates a lot of diagnostic problems. I mean, the differential, there are about 30 different conditions which can cause it. I try and differentiate between progressive and non-progressive disease. And if you take the progressive causes, in countries where trachoma is no longer a problem, mucous membrane pemphigoid is the commonest cause, atopic keratoconjunctivitis, drug-induced scarring and inflammation due to glaucoma drugs, not just the preserved ones. The non-preserved ones will cause a lot of inflammation and scarring. In a few cases, ocular surface neoplasia and atopic keratoconjunctivitis. And then there's a long list of other cases as well.
But how would you, what would you tell a clinician that what should they look out for in the early cases? It's pretty obvious in the late stages, but in the early stages, what should they look out for?
Well, if they have a patient with recurrent inflammation of uncertain cause, they need to look for signs of scarring. That should flag up the fact the patient may have a scarring disease. And with early disease, if you look, you don't necessarily see. So you have to have it in the back of your mind and look for signs of scarring. The plica semilunaris, that scars first, often just subepithelial scarring in the upper tarsal conjunctiva, subtle signs of fornix shortening. So if you don't think about it, you won't actually see it. Yeah. And it's important to have it in the differential of any cause of chronic relapsing conjunctivitis.
Thank you. And once you've made the diagnosis, then do you have a protocol? How do you approach the management? Do you start with topical and then immunosuppression, or do you not make that distinction?
Well, I think it's important with the immunobullous disorders, and that's principally pemphigoid, but it also includes mucosal-dominated epidermolysis bullosa acquisita, which is pretty rare, and linear IgA disease. You really are obliged to do or recommend that the patient has the specific investigations for that, which are direct and indirect immunofluorescence. The direct is done on a conjunctival biopsy, looking for immunoglobulins at the basement membrane, and the indirect is using patient serum to identify antibodies that actually attach to the basement membrane in salt-split skin and on other substrates. So you need to do those tests, but having said that, it's important to realize that they're negative in between 50 and 80% of patients who we're pretty sure have mucous membrane pemphigoid or an almost identical disease, but in whom the tests are negative. And that's important when you're trying to convince people to help you treat these patients with immunosuppression, because topical therapy is no good for the pemphigoid group of disorders. It may well work for some of the other causes we've discussed.
And when you talk about biopsy, would you distinguish between conjunctival biopsy, you mentioned conjunctival, or oral mucosal biopsy?
It can be a biopsy from any site, and the oral mucosa may be positive, as you perhaps suggested, when the conjunctival biopsy is negative, even in patients who don't have oral disease. So I always do both sites. If there are other sites involved, you don't have to have a biopsy from the conjunctiva. If you've got typical clinical signs and a biopsy is positive from any other site, including skin, that will make the diagnosis.
Right. And what is your choice of immunosuppressive agent that you would use?
It depends on the severity of the disease. So if patients, about 1 in 10 of the patients, new patients I see, come with really quite severe inflammation, including limbitis, which is devastating and leads to stem cell failure and blindness over a period of 6 or 8 months. And these patients need rapid control of inflammation. So the bad ones, I start with high-dose oral prednisolone, tapered over 3 months. At the same time, I start a steroid-sparing drug, and cyclophosphamide is the best drug, or has the best evidence for use in severe disease. If they're not so severe, you can use less potent agents, such as mycophenolate or azathioprine. But if we start at the top of the stepladder for the severe disease, prednisolone and cyclophosphamide, if there's no sign of any improvement at the 4-month stage or a patient relapses, then we now go to rituximab. There's a big problem with accessibility to that in the UK, as you know, at the moment, which is something we're trying to deal with as a group with the NHS. But rituximab has looked very promising in the case series that have been published for severe patients, but very few of mine I have to apply maybe for rituximab once or twice a year. I can deal with most of them with prednisolone and cyclophosphamide. And once you've got the disease damped down, a lot of these patients will go into remission for a time, and then you can use, I add in dapsone before stopping cyclophosphamide, and if necessary, use mycophenolate or azathioprine. If they're mild cases, I'll start with dapsone and work up through that series of immunosuppressants.
And any quick comments on surgery and these conditions? And would you go for punctal occlusion or plugs, or would you recommend people not do surgery or defer surgery?
Well, the lacrimal puncti have often been auto-occluded anyway by the disease. And surgery is a medical failure if you need to do the surgery for the disease, and we have to. Patients with immobile eyes and corneal exposure because the lids are stuck, we can do fornix reconstructions, and in fact the results are pretty good if you do those once you've got control of the inflammation. If you don't, as you well know, if you don't control the inflammation, you may get a severe exacerbation of disease. But ideally, we should see these patients early and treat them promptly. And the diagnosis, on average, in that study we did, it was taking the median time to diagnosis was 2 years from the first symptoms. It's too long.
And briefly, would you tell us then what's on the horizon? What's coming? Are we still stuck with these immunosuppressive agents or something else?
Well, I think this is quite exciting, and this is one of the things I'm going to address in my lecture this afternoon. We've known, first of all, we know that if you can control inflammation, you can slow down the scarring, which leads to a lot of the morbidity, severe dry eye, entropion, trichiasis, lagophthalmos. But it doesn't actually stop the scarring progressing in about half the cases. So it's critical to get rapid control of inflammation, and the current drugs we have, like cyclophosphamide, take too long. I mean, we've completed a randomized trial, and one of the readouts was the time it took to control inflammation, and it was 20 weeks. Now, other studies have put it at about 12 weeks with cyclophosphamide, but during that period, patients will get a lot worse. Rituximab is looking very good, and it might be extremely good in early disease. Currently, it's only used for patients who've failed all the other therapies, and it takes less long to work. It looks like about 10 weeks, but we don't have a prospective study in rituximab, which we'd love to do. So rituximab is very exciting. We don't have any local therapies on the horizon for controlling the inflammation, although there is potential for the TNF inhibitors given subconjunctivally. That's all possible. And we've been looking into the scarring for 20 years and finally have some exciting results in an in vitro model and in a mouse model. And we've, I believe, shown pretty convincingly that aldehyde dehydrogenase is produced by the fibroblasts, the scar cells in the conjunctiva, and they auto-regulate once the disease has been switched on. And we can switch off the abnormal behavior with an ALDH inhibitor, and that's available as antabuse. And also, we can take the downstream product of ALDH metabolism, which is retinoic acid, and switch the control cells into behaving abnormally in a whole series of assays. And we can replicate that in a new mouse model of inflammation. And we can switch off the scarring in vivo in the mouse. So we would like to take this forward.
Thank you very much. Look forward to hearing your lecture.
Thank you.
Thank you for joining us. For more information on this and related topics, please visit us at eurotimes.org.